Hello, everyone. Welcome to this session. All right. Today we're going to be starting from gastritis, or actually the stomach pathologies. Stomach pathology. Okay, so the first thing we are going to be looking at is gastritis. Gastritis is two types. One thing is acute. Something happened acutely that caused gastritis acutely. Then there's chronic. Something has been happening that leads to chronic sort of gastritis. So what are the acute things that can lead to gastritis? So you have the erosions can be caused by. So what is an erosion? Erosion is basically when you lose the superficial epithelium. Okay. Versus, what's the difference between erosion versus ulcer? Ulcer is when you lose your mucosal layers. So again, this is just superficial. This can heal up. But if you have an ulcer, you are losing the mucosal layer of the cells of the epithelium, leading to loss of stem cells. Loss of stem cells. So in ulcers, you are losing the stem cells. So here we are talking about erosion only, okay? But the thing is, what are the things that causes acute gastritis? Very important. NSAIDs. How? When you give NSAIDs, what's going to happen is you have a decrease in prostaglandin E2. And what is normally prostaglandin doing? So normal prostaglandin, they are normally increasing your mucus production and bicarb production. One thing. Second thing, they're also increasing the blood flow so that whatever acid remains, they can just go into the blood. Third thing, it decreases. This is all about prostaglandin E2s. Third thing, they decrease the acid production itself. So when you knock this out, when you knock out your prostaglandins, you got decreased gastric mucosal protection for sure. So who's doing that? That's NSAID. Second thing, you have the burns. That's the curling ulcer. The mnemonic is here, which is really good. Burned by the curling iron. So you do get burned by the iron, but here the curling iron, curling ulcer. That burns are going to get you in hypovolemia. That hypovolemia is going to go into ischemia. So you will have mucosal ischemia. So not just this. Let me change the color here. You have to also think about not only this, but what else would give you an hypovolemia? Well, if you have a shock will give you hypovolemia. Same thing is going to cause you mucosal ischemia. What else? Portal hypertension can give you hypovolemia to the gut. So you are going to cause mucosal ischemia in portal hypertension. So in any case, if you have all of these things, it causes hypovolemia is the main thing, which causes ischemia. What's going to happen then is you have, after ischemia, you have decrease when the mucosa gets ischemic, that mucosal protection has been lost. Right? So you have a decreased mucosal protection. So when you have a decreased mucosal protection, guess what? Now you are going to go into erosions, as you mentioned here, erosion, or ulcer, even ulcer formation. And that even erosion ulcer may perforate. And if they were to perforate, that can lead to bleeding. Okay. So that's through all of it, looking at through hypovolemia. but burns causes curling ulcers. Brain injury. Now let's change the color here. Brain injury causes Cushing ulcer. Well, this is pretty easy. Cushing syndrome, Cushing disease, Cushing brain things, right? Cushing ulcers. But just remember this mnemonic. Cushion the brain. Okay, so that's the brain injury. But how? How does the brain injury causes acute gastritis? Well, brain injury is going to increase your ICP, intracranial pressure. That will stimulate your vagal stimulation, which is acetylcholine increase in acetylcholine release. That acetylcholine release is going to stimulate your parietal cells. Remember that parietal cells, acetylcholine. Parietal cells are going to give you increase in hydrogen production. And same thing follows. Erosion, ulcer, perforate, bleeding. Same thing. Okay. Okay, on the right side, what do we have here? Especially common among the patients with alcohol use disorder and those taken with NSAIDs, right? For example, for rheumatoid arthritis, yeah, sure. And you take NSAIDs or you're in the alcohol use disorder, it's going to get you acute gastritis. Okay. What else? So we got two sort of people, but one more thing. We have the chemo patients. In chemo patients, they have a decreased cell turnover, right? And that is going to lead to, because they have decreased cell turnover, acid is going to damage these cells. So it's going to give them ulcers or erosions. Okay. Yeah, so that pretty much... that's pretty much it for the acute gastritis. So now let's talk about the chronic one. How do we get the chronic? For the chronic, you're looking at, you have a chronic mucosal inflammation, often leading to atrophy, hypochlorhydria, leading to increase in hypergastrinemia. Hyperchlorhydria meaning you have a decrease in hydrogen production and they are produced by the parietal cells. Hypergastrinemia, whenever you have a decreased hydrogen acid, as we talked about it yesterday, the gastric, the G cells, the gastric cells, the gastrin secreting cells, they will secrete gastrin more. So to compensate that decrease in acid. So that's why you have hypergastrinemia. And because you have chronic inflammation, it's going to lead to intestinal metaplasia because of all that chronic inflammation. And that metaplasia is always, you can see that it increases the risk of gastric cancer. So that's generally, that's what we see in chronic gastritis. Now there are two types of chronic gastritis. One thing is autoimmune. One thing is H. pylori. Second thing is autoimmune. H. pylori is the most common one. It increases the risk of peptic ulcer disease and malt lymphoma or maltoma, right? So in chronic gastritis, who's the causative agents are either your H. pylori or you're the autoimmune. You have the autoimmune disease. In H. pylori, all you are getting is PUD, which is PUD, peptic ulcer disease, and maltoma. Now, this is important, that where does it affect? It affects the antrum. Antrum, remember, antrum is the end part of stomach. So antrum first, and then spreads to the body of the stomach. So it goes up towards the body. First, it starts at the antrum. So, and the other one, let's talk about autoimmune here. Autoimmune, these are the autoantibodies, T cell induced to the H potassium ATPase on the parietal cells. So hydrogen potassium ATPase on the parietal cells. You have autoantibody against them. and to the intrinsic factor. So because you don't form the intrinsic factor, again, here you go, pernicious anemia. This is basically due to vitamin B12 deficiency. But here the location is different. So when it's autoimmune, it affects the fundus and the body. It doesn't go into the antrum. While H. pylori, it affects the antrum first and then goes back to the body. Well, here it just messes up with the your fundus in the body. And these are autoimmune autoantibodies. Okay. Now, if we were to talk about how we have this intestinal metaplasia, change color here. So that intestinal metaplasia, because of the chronic inflammation, you have this, right? And formation of intestinal epithelium as they have Peyer's patches. And why do we need the intestinal metaplasia in the stomach? Because the intestine contains the Peyer's patches. So we are looking for that. That's why you have the intestinal metaplasia. But since you make the Peyer's patches, now you are concerned that it's going to lead to the formation of gastric carcinoma, wish type adenocarcinoma, and it's going to be coming later at the bottom. But this is all for the chronic gastritis. So just got to know the location and the causative agents. And other than that, you can just make up things on your own. H. pylori infection, autoimmune. Okay, one more thing here. What is the risk factor for H. pylori infection? Well, the risk factor to get an H. pylori infection is the poverty, developing countries. So an immigrant who is coming here, he's going to get an H. pylori infection. Now, one extra thing, H. pylori does not invade the mucosa. It just sits on the surface epithelium. It just sits on the surface epithelium. Okay, and it releases two things. One thing is the proteases, and second thing is the ureases. And these two things, they lead to weakening of your mucosal protection. So it doesn't even invade, just sits on the epithelium, releases these, and decreases your protection of the mucosal epithelium. Okay. So yeah, let's go with the next thing. What do we have? Now we have here, this is Menetrier disease, hyperplasia of the gastric mucosa, leading to hypertrophy rugae, wavy like brain. Look at this. I mean, it just looks like your brain, right? Like the brain gyri. Causes excessive mucus protection. Why you have excessive mucus protection? Because remember, what's really happening here is you have the gastric mucosal hyperplasia, right? Just the mucosa has underwent into hyperplasia. And one important thing is why. Question is why you went into hyperplasia. So the reason to that is it is the overproduction of TGF alpha. It's a precancerous state in which you have overproduction of TGF alpha, which stimulates those gastric mucosa. They undergo hyperplasia. When they undergo hyperplasia, they get the formation of that hypertrophy rugae, or like brain gyri structure, and resulting protein loss. because you're secreting and making so much, you have a protein loss and parietal cell atrophy with decreased acid production. Whenever you have a parietal cell atrophy, you have a decreased acid production. Now, how does it present with? Well, it presents with weight loss, because you have a protein loss. You're just losing a lot of things here. Anorexia, vomiting, epigastric pain, edema. Again, protein loss leads to edema due to protein loss. Announced wave, pronounced as wave. Weight loss, anorexia, vomiting, epigastric pain, edema. Think about this thing, and this thing, total extra. So when you have these things together, you can have a vomiting and epigastric pain in a lot of things, right? But you have a weight loss with anorexia, with edema. Okay, that's a wave. Nature is due to TGF alpha overproduction. It's a precancerous state. Okay, coming to the gastric cancer. Well, the gastric cancer is most commonly gastric adenocarcinoma, lymphoma, GI stromal tumor, carcinoid, that is rare, early aggressive local spread with node liver mets, often presents late with weight loss. So it does present late, often does present late with weight loss as a normal. With all cancers, you have weight loss. Early satiety and abdominal pain. Okay, obstruction, and in some cases, very important, acanthosis nigrans. So this sign, acanthosis nigrans, is associated with two things. One is the gastric cancer. Second thing is the insulin resistance. That is the acanthosis nigrans, or the lesser Trellat sign. The lesser Trellat sign. The demonic here is the weapon. But again, they will give you some histo. So let's talk about that. So you two types. One is intestinal and second is diffuse. Intestinal is associated with H. pylori, dietary nitrosamines, smoked food, common in East Asian countries, tobacco smoking, achlorhydria, chronic gastritis. So again, look, where did we go? Okay, chronic gastritis, H. pylori, okay, and commonly involves on the lesser curvature, looks like an ulcer with raised margins. Again, ulcer with heaped up raised margins or irregular margins is always suspicion. You should have a suspicion for cancer. Okay, that's the intestinal type. So intestinal type, kind of like chronic gastritis, leads to intestinal type. Second thing is diffuse. It is not associated with H. pylori. It is due to EC-adherent mutation. Now, there's a new thing now. EC-adherent mutations. You have a signet ring cells. So look at these pictures, signet ring cells, in which you have the mucin filled cell with peripheral nuclei. Like this guy is peripherally present, and all this. And the other thing is just mucus. That's the signet ring, like a ring type thing. Signet ring, right? And again, one thing is the signet ring, and the other thing you have to see is the linitis plastica, which is stomach wall, grossly thickened and leathery. So thickened stomach wall. Okay, so now this gastric cancer is associated with Werkow's node. There are the involvement of the left supraclavicular nodes. So left supraclavicular nodes by Mets from the stomach. Kuchenberg tumor, that's the Mets 2 ovaries, typically bilaterally, abundant mucin secreting signet ring cells. So this is more likely to go from diffuse. If you have a diffuse type of cancer, it's going to go into ovary and cause Kuchenberg tumor, and could be into bilateral ovaries. And how these mets come to the ovary, right? Ovary is like way down, and the stomach is way up in the chest, and like it's way different, right? How do we get that? It's through blood. How do we get that? Mets, blood, hematogenous spread. Okay. What else? Yeah. So this is with the diffuse, and with the intestinal type, you will see Sister Mary Joseph nodules. They are the subcutaneous periumbilical mets. It's just subcutaneous periumbilical mets. Okay, they are the Sister Mary Joseph nodules. That's with the intestinal type. And Bloomer shelf. They're the palpable mass on the digital rectal exam, suggesting mets to a rectouterine pouch, or the pouch of Douglas. Okay. What else? So this lesser tralad sign. So this is basically sudden appearance. You have a sudden, like the guy is all good. Anyone, God forbid, nothing happened to anybody, but sudden appearance. You have appearance of multiple seborrheic keratosis. What do I mean by multiple seborrheic keratosis? It is basically pigmented skin lesions, like ... Sudden appearance, right away they appear. That's the lesser tralad sign. Okay. What else? So when you lose your EK adherents here, if you lose these EK adherents, then these, remember, EK adherents are keeping them together so they're going to go infiltrate the close by tissues. Okay. Yeah, that's pretty much all we have. So diffuse, important thing is this diffuse type, it is not, remember they have mentioned, it's not associated, this is very important, it's not associated with H. pylori. And it is not associated with nitrosamine foods or any autoimmune gastritis. Well, this guy, it is associated with all of that. Okay, and also the other things that this guy is associated with is the obesity and high salt. Now this is very, you will see this question and you'll be like, what are they even asking? This intestinal type is associated with high salt diet. Okay. And obesity. Okay. So that's all for the, I guess, so we will be continuing the intestine, or we could just actually do this first. Yeah, let's just do this.